But even over the age of 40, the organs are deteriorating. So what John Cassack's team came up with was a scheme for sharing all deceased brain-dead donor or heart-beating donor kidneys. They're all now shared nationally and have been so for a couple of years. And it's a complicated, in practice, although actually the principles are pretty simple. There's a point scoring system where patients accrue points for time on the waiting list. So patients have been waiting for several years on a very large number of points. The scheme favours HLA matching, but particularly HLA-DR and HLA-B matching. Those are the most important antigens for matching kidney transplantation. And the scheme also tries to avoid putting very old donor organs into very young recipients and vice versa, because this is poor use of organs. Now, so much for heart-beating organs. This slide shows deceased donor organs according to the heart-beating ones and the so-called donation after cardiac death, which is the pale blue or the Cambridge blue at the top there. Essentially, there's been a dramatic increase over the last decade of kidneys from patients who have been diagnosed dead by conventional means. In other words, the heart stops, death is certified after a short period of time, the stand-down time is about to pass, and the patient's taken to theatre and the organs are removed. There are large regional variations in these non-heart-beating donor kidneys, and you can see there, for example, Cambridge and also Plymouth got really proactive programs and got a very high number of non-heart-beating kidneys per million population. And I think it's just a matter of time before most of the other centres actually reach similar levels. So I think it's likely over the next 3 or 4 years that kidneys from non-heart-beating donors will become the dominant deceased donor type. Now that's a fact. There are various reasons why that might be the case. There's a change in neurosurgical practice, so there's a lot of cranial decompression surgery now. There's also more prompt and effective treatment for intracranial hemorrhage from aneurysms. And so the nature of the patient in intensive care has changed, and I think this is really driving this change towards non-heart-beating donors. So donation after cardiac death, most of the donors in the UK are so-called controlled donors, so their treatment is withdrawn and the donor obviously dies. They've nearly all got massive neurological injury. It's been deemed by the doctors looking after them that further medical intervention is futile, and therefore they're disconnected from the ventilator, life-supporting treatment is withdrawn. You wait for cardiac arrest, cardiorespiratory arrest, diagnose death, and then there's a standoff period of at least 5 minutes in the USA and in the UK guidelines. It's often a little bit longer than that, and then the patient is, or the donor now, is taken to theatre and the organs are removed. Unlike heart-beating kidneys, there's a significant delayed graft function rate, around about 50% versus something like 20–25% for heart-beating kidneys. And that's really because of this period of warm ischemic injury. Now, one of the problems with this approach is that there's really not very good data, but it's very clear that many non-heart-beating donors never come to become donors. They never die in a suitable time period. And it's very difficult to know who's going to die when. So that creates all sorts of problems in having theatres available and transplant procurement teams waiting and so forth. So we carried out a multi-center study, which was published earlier, well actually last year now. It was a prospective study looking in 9 different UK transplant centres. We looked at 191 potential DCD or donation after cardiac death donors. Half of those actually went on to become donors. The death in all these cases was attributable to severe neurological injury, and treatment withdrawal consisted of either extubation 80%, disconnection of the ET tube and 20%, discontinuation of drugs, of various supportive measures. And then we looked at time to death and factors which may allow one to better predict time to death. Now, all of these patients did go on to die, although only half actually became organ donors. Most of them died pretty quickly in the first hour, and the median time to death was about 36 minutes. That was influenced by the type of donors. So those with trauma, for example, died more quickly. Those with hypoxia took longer. One patient took 3 days to die. So there are many issues about knowing when these patients will die. In America, until recently, the deal was unless the patient died within 1 hour, then the procurement team backed off and the patient didn't become an organ donor. You can see, if you stick rigidly to 1 hour, then we lose a significant number of donor organs. So we looked at the factors which influence whether patients die quickly or more slowly after withdrawal to treatment, and these are essentially the results of a detailed analysis. So that many things had no predictive value whatsoever, and in fact the only things which did predict early death were the cause of death that I've already shown you. So trauma, patients died more quickly after withdrawal treatment. Younger patients died more quickly. Those on ventilatory pressure support, and those with a high FiO2 in their ventilator died more quickly. And this was a start. What's needed now is better information on what factors in this type of donor actually relate to how organs do after their transplant. So I think there's a huge gap here in work that needs to be done. Now the surprising thing is, despite the fact that from non-heart-beating donors they've incurred anything up to an hour of warm ischemia, kidneys from these donors do pretty well. In fact, they do as well as those from heart-beating donors, as shown here, both for kidney graft survival and for patient survival. And this is probably partly due to the fact that these kidneys don't suffer the hormonal and metabolic problems that brain death donors have. And the nature of the injuries is very different. So, although they've got a high immediate non-function rate, they actually do pretty well in long term. So there's no reason why we shouldn't be enthusiastic about using organs from these donors. Currently, these organs are not shared in the national sharing scheme. They're quite separate, and they're used locally by the local procurement teams. It's obviously, if they're going to become the dominant source of kidney, it's important that we do look at whether they can be shared. So work's currently being done by one of our PhD students looking at the factors in non-heart-beating donor kidneys which predict outcome after transplantation. And the story is essentially that old donors do badly, just like the heart-beating kidneys. Recipient age is also an issue. Cold ischemia time, this time below 12 hours, is detrimental. For heart-beating kidneys, it was 21 hours. So these kidneys are less tolerant of storage. Now, for these kidneys, HLA matching had no benefit. So that is different to the heart-beating kidneys. So there doesn't seem, at least on the data so far, any particular advantage in HLA matching these kidneys, except there is a problem if you do a poorly matched transplant that you may sensitize the recipient, it may make repeat transplantation more difficult. The other interesting thing is that delayed graft function in these kidneys, and remember half of them don't function for several days, sometimes several weeks. As long as they function eventually, delayed graft function doesn't have any detrimental effect on long-term outcome, which is quite different to heart-beating kidneys. So there are a number of important differences. Now, moving on to living donor transplant, that's a pair we transplanted. That was a wife-to-husband transplant, which, as you can see, both donor and recipient a couple of days after the operation, very pleased with the whole thing. Now, living donor transplant is becoming much more common. For a recipient to use a kidney transplant, it is undoubtedly the best thing. So if any of you've got kidney failure and you think you're going to transplant, then it would be highly desirable to find yourself a willing, appropriate living donor. If we look at 10-year graft survival, then it's 75% for living donors compared to 67% for deceased donors. So deceased donors are pretty good, but living donor transplants are better. And that also holds for repeat grafting. Now, numbers of living donor transplants have increased over the last decade, although there is a feeling they're probably going to plateau off now because a lot of the, at least a large part of the unmet need has been met. And in the US, a little bit ahead of us, they've been static now for the last 4 or 5 years. So there has been a big increase in living donor kidney transplant, both in genetically related, but particularly in genetically unrelated donors.